Hello everyone, this is Dr. Mohammed Anis from Cairo University. I'd like to thank Dr. Professor Bilmeki for inviting me to such a prestigious meeting. And the topic of my talk today is chemical burns, and I'll try to um, highlight the use of Boston keratoprothesis in such cases. So I'm starting the slideshow now, and let's see. So I have no financial disclosures related to this topic. Okay, so we know that the incidence of ocular traumas is around 7 to 18% of the ocular traumas are due to chemical burns. They represent also 15 to 20% of any facial burns. So this topic is very common. Unfortunately, most of the victims are young, male. 60% of these cases are related to the work environment. And a very common scenario is using the housewives while using the domestic detergents. Acids, alkalis are more common than acid burns. However, acids have a better prognosis as they usually have a lower pH than the human eye, which cause them to precipitate the tissue proteins and act as a barrier for further penetration, except for the hydrofluoric acid. However, alkalis are lipophilic and they can easily penetrate the eye and deposit within the tissue more rapidly. So they are more destructive to the eye. First classification was in the mid 1960s by Bellin, then modified by Robert Hall classification, which depended on the clarity of the cornea and the limbal blanching. He staged the chemical burns into 4 degrees. Stage 1 with a clear cornea and no limbal ischemia at all. Stage 2 with some corneal haze and the limbal ischemia less than 1/3. Stage 3, the iris details start to be obscured and you cannot see the iris clearly, and the limbal ischemia of 1/3 to half of the cornea. Then stage 4 with an opaque cornea and limbal ischemia more than half of it has a limbal ischemia. Then in 2001, Dua and his co-workers made a new classification, which is, I think, one of the most important classifications that we use now. And this classification used the clock, limbal clock hours, together with the involvement of the bulbar conjunctiva. The first, it has 6 grades, so the first 3 grades have very good prognosis, and this is important that not just with the classification you have now, you can also relate the injury to the expected prognosis. So the first 3 grades ranging from 3 to 6 clock hours, with grade 1 0 clock hour involvement, grade 2 less than 3, and then grade 3 3 to 6 hours of limbal involvement. While the bulbar conjunctiva ranges from 0 up to 50% in these first 3 grades. And for grade 4, 5, and 6, unfortunately, they have guarded prognosis. We have cornea involvement, of limbal cornea involvement, more than 6 hours up to 12 for the total limbus, and the bulbar conjunctiva ranging from 50% up to 100%. What about the clinical course of such cases? So McCulley said that the clinical course has 4 stages. We have the immediate phase, which this once the contact occurs with the chemical burn, and it is very important to document the extent of the cornea, conjunctiva, and limbal blanching during this phase. Then we have the acute phase, which usually day 1 to day 7, and during this period, the tissue starts to rid themselves of the concomitants and starts to re-establish the superficial protective layer of the corneal epithelium, which acts as a barrier between the enzymes found in the tear film that can lead to corneal thinning and progression to perforation. So it's a balance, very important to balance this. Then, starting from day 8 to 20, this is the early recuperative phase, and this is a transition phase from the acute inflammation to the chronic inflammation and the stromal repair and scarring. Then the late phase, which is usually 3 weeks from the incident, and here we have two roads. We either go for completion of the healing, like in grade 1 and 2 and 3, 1 and 2, or the occurrence of complication starting from grade 3 or 4, if we're talking about Robin HAL classification, or going to do again starting from grade 4, 5, and 6. And complications in such cases are multiple. We can have cornea scarring, symblepharon, anclepharon, ectropion, entropion, glaucoma, cataracts. So the clinical burden complications are vast and a lot. Now we move to management. How do we manage these cases? So the initial evaluation and immediate treatment is very, very important. At this stage, this influences a lot our final outcome. One should not wait for a careful assessment. It is very important just to have a brief history and start the treatment right away and not to delay it prior to any very thorough ophthalmic evaluation. We need to do a corpus irrigation with isotonic saline, sometimes up to 20 liters and more. And the aim of this is to try to neutralize the pH pH of the eye to the physiological level, which is usually 7.4. Then comes the acute phase. And in the acute phase, this is the start of the challenge of starting the healing. And our major goal in this phase is to re-establish and maintain an intact, healthy epithelium, and to, as we said before, to control the balance between the collagen synthesis and the collagen lysis substance. So it's a balance. In this stage, we give topical antibiotics, broad spectrum, cycloplegics, anti-glaucoma, topical prednisolone 0.5% hourly to reduce the inflammation. However, together with the prednisolone, we have to give substance that promote revitalization. We start with tear substitutes, which we have to use preservative-free ones, bandage contact lens, hydrophilic contact lenses with high oxygen permeability to promote the healing, sodium ascorbate drops, very helpful, 10% hourly, oral vitamin C, 2 grams per day. In case we have any necrotic epithelium, we should deprive this epithelium to give chance for the healthy epithelium to work. Now at the early recuperative phase, we should have an intact epithelium. If this has not been established, then here we have to go more for an aggressive therapy. Steroids should be discontinued, lubricants used more, punctal plugs, tersaraphy, punctal occlusion. We continue on the anti-glaucoma antibodies, and here sometimes we notice the starting of formation of symblepharon. Then in the late recuperative phase, now at this stage we're around 20 days from the incident, and if we don't have healing, a good healing, then we may start to see complication that may cause permanent visual loss. And at this phase, we start the surgical modalities and treatments for such cases. We usually use them at this point. And there's a lot. There's like conjunctival and tendon advancement, tissue adhesiveness, adhesive material, the therapeutic penetrating keratoplasties, amniotic membrane use. There's a lot. The latest phase is the rehabilitative phase, and patients with grade 5 and 6, we either have to go with the limbal stem cells transplant, which is very successful, either from an uninjured fellow eye or a blood relative or from other like donor patient. But the problem with the limbal stem cells that they need very good post-op and pre-operative preparation regarding the immunological state of the patient, and need a lot of help from our fellow internists to help us control and balance the immunity of the patients, and a lot of systemic drugs. And the other option would be the keratoprothesis, especially the Boston keratoprothesis, which I think are a game changer in these patients. I'd like to share one of my patients that had a bilateral chemical burn. This was like 2-3 years ago. He had this chemical burn bilateral, so the decision was to go for a Boston keratoprothesis. For those who do not, so for those who do not know the Boston or are not familiar with the Boston keratoprothesis, it's made of 4 parts. We have the front part, then the cornea graft, backplate, and the locking ring. We start with the punch. I usually use 8.25 punch, just like any normal keratoplasty. Just make sure that you have a sharp cut. Now checking the cut. Okay, well centered, good. With the parts that come, there's like an adhesive tape that you assemble the Boston K-Pro on it to just avoid slipping while during the assembly, because most of the parts are PMMA or plastic, so it could be a little bit slippery. You remove the adhesive, the small adhesive tape very soon. I think this is the most important step. You punch the graft centrally with a 4 millimeter tissue punch. This is a little bit very difficult. You have to be very well centered, avoid slipping of the graft. If you're decentered, then the backplate would be also decentered, making all the Boston keratoprothesis a little bit bigger, and it gets difficult to insert inside the eye and may cause also problems and glaucoma afterwards. Then this is the front plate. Then we place the corneal graft on it. Then the backplate, which we either have a PMMA or titanium one. Then the locking ring. As we see, then we compress the parts together very carefully until we hear a clicking sound. You have to be very cautious not to break the locking ring at this point. These patients, I'm really sorry about the date. This is not the real date, but the camera was set on this date, unfortunately, by mistake. So these patients have usually, sometimes it's difficult to identify the limbs, and in such cases, maybe it is better to use an endo probe that helps you to identify the limbus. Once you have a clear limbus, start refining the cornea manually. And I don't really like the suction refination in these cases. You have really thick corneas and they are highly vascularized. So you have to be really cautious and slow in these cases to avoid having massive bleeding. Definitely this video is edited. Usually you get cataracts inside the eye. We have two modules with the keratoprothosis. You either have the aphakic module or the pseudophakic one. So the aphakic goes for aphakic patients and cataractus patients. You do an anterior vitrectomy just to compress a little bit the eye and avoid if there's any vitreous hemorrhage to remove it. Together, then we place the keratoprosthesis. I usually suture 16 interrupted sutures. Suturing is not an issue. Just the last trick is to tuck in the keratoprosthesis because we have a backplate of an 8.5 millimeter that you have to want to insert it inside at 7.75. It's not that difficult. Once you do it a couple of times, you get the hang of it. I suture really take a really tough. You don't have to worry about stigmatism in these patients. There is no effect of astigmatism for the sutures, so you have to take them as tight as much as possible. After having the first 4 sutures, it's really easy. Just make sure that you don't go through the holes, just the cornea. And you have this is like the 4 corneal sutures. Make sure that's tucked in. This is the first day post-op. So this is 10 days after the surgery. This is a video with the patient. Unfortunately, it's in Arabic. So I'm asking him what he was seeing with the surgery, and he said just like hand motion. And then we'll check the chart and see what he can see, what's his find. This is, again, 10 days post-operative. So the patient can see 0.3. This is definitely not the case in all patients. Sometimes you have a vitreous hemorrhage and the patient has to wait till this vitreous hemorrhage clears. And you have to explain that you have some bleeding inside your eye. So for you to see this bleeding has to clear out. But definitely it's a solution to a lot of these problems. We give antibiotics daily for life, soft contact lens that he has to wear. The big issue is glaucoma. So you should have one of your glaucoma friends with you. If patients are diagnosed with glaucoma prior to the operation, then maybe it's a good idea to have an Ahmed's valve placed before the surgery. There are hypotensive drops for life. Every 3 months, we have to check the IP digitally because there is no other way to check it. CD ratio, every 6 months, we do a field if possible, retinal fiber layer thickness, and every 12 months, disc photo. So for the conclusion, chemical burns, it is very, very important to have an immediate evaluation and intense treatment. Our aim is always to restore the normal ocular surface and anatomy. And thank you for your attention. Again, I'd like to thank Professor Ben-Melki for inviting me to such prestigious meeting, and hopefully next time I can come and attend personally the meeting in Morocco. Thank you so much.